Hello everyone. In this lecture, I would like to complete the last few slides which I had left it out during the cardiovascular system part 2. Let us go through it one by one. Control of blood pressure. Blood pressure is mainly controlled by a short-term mechanism and a long-term mechanism. The short-term mechanism counteract moment-to-moment changes in the blood pressure by altering the peripheral resistance. That means it can control over the blood vessel, the diameter of the blood vessel. It can control the diameter of the blood vessel, thereby the peripheral resistance can be altered. And we have seen how the blood pressure diameter, the blood vessel diameter can be controlled. How the blood vessel diameter can be controlled. I mentioned the arterioles are richly innervated by sympathetic nervous system. So whenever the sympathetic nervous system is stimulated, it will be sending the impulses to the arterioles and the arterioles will be contracting. And arterioles is considered to be the seat of peripheral resistance. And whenever the sympathetic nervous system is active, you can expect that the peripheral resistance is increased. Whenever the peripheral resistance is increased, that means the workload over the heart is greater. The heart has to overcome that resistance by pumping forcefully. There is a neural control which is very rapid, and there is a hormonal control which is less rapid. The long-term control of blood pressure is through the kidney. It is quite slow in its action, but it is very effective to bring about the control in the blood pressure. They mainly affect through the total body volume. Actually, the kidney is one of the important structure which is controlling the extracellular fluid volume, and we have seen that how the ADH can act through kidney. Aldosterone can influence on kidney by increasing the sodium reabsorption and so on. Coming to the control of the blood pressure. Vasomotor center is a special vital center that is located on the medulla. And in the medulla there are so many other vital centers like cardio inhibitory center, respiratory center, vomiting center, etc. And the vasomotor center, when it is stimulated, it will be activating the sympathetic nervous system. It will be increasing the cardiac output. It will decrease the blood vessel diameter. As I mentioned, you can see in this how come the blood vessel diameter is affected whenever there is the sympathetic activity. Once again, you need to think of what the sympathetic nervous system will do on the arterioles. Whenever the sympathetic nervous system is active, it will be making the constriction of the blood vessels and thereby reducing the diameter and increasing the vascular resistance. The end result will be an increase in the blood pressure. In response to specific demands like exercise or a change in the body's position, this neural control changes distribution of blood by altering the blood vessel diameter. Neural control of blood pressure. One of the most important neural control is a baroreceptor reflex, which is involved in the short-term regulation of blood pressure. Within fraction of seconds, there will be changes which can be brought about in the blood pressure. MAP is the mean arterial pressure. Mean arterial blood pressure is called MAP. Mean arterial blood pressure is constantly monitored by pressure sensors that are located in the carotid sinus. Remember these terms, carotid sinus and aortic sinus. Aortic sinus is present in the arch of aorta. Carotid sinus is again a bulge structure where the common carotid artery divides into internal and external carotid artery. So that is actually, what are these receptors? These baroreceptors, which are actually the stretch receptors which can respond to stretch. how it can respond to stretch, which means when blood pressure is high, there is more amount of stretching of the blood vessels, and this stretching of the blood vessel also stretches the baroreceptors. The baroreceptors will be actually stimulated whenever the blood pressure is very high. An increase in the pressure causes the walls of these regions to stretch. Baroreceptors then send the signals to the cardiovascular center in the medulla, and then it will be inducing a decreased sympathetic discharge. Now you need to remember why there is a decrease in sympathetic discharge when the cardiovascular center in the medulla is activated, right? There are two centers again. Now in this relation, there are two centers you need to remember. A vasomotor center, when it is stimulated, it will be stimulating the sympathetic nervous system. When the cardioinhibitory center or the cardiovascular center, when it is stimulated, that will be stimulating the parasympathetic nervous system, that is the vagus nerve, through the vagus nerve. So in this case, what will happen is whenever the cardiovascular centers are stimulated, there is a decrease in sympathetic discharge will take place. Then there is an increase in the parasympathetic output. When the parasympathetic nervous system is active, you can expect that it will be having an inhibitory influence on the heart. There will be a decrease in the heart rate, decrease in the stroke volume, and thereby the cardiac output also decreases. There will be arteriolar and venous vasodilation. The end result will be a fall in the blood pressure towards normal. Remember, all these things started with an increase in the blood pressure, and finally, as a result of baroreceptor reflex, the blood pressure has come back to normal. So this is again a reflex mechanism, a feedback mechanism. Look at the baroreceptor activity under normal pressure condition, when the pressure is high and the pressure is decreased. Here in the graph you can see that these are the arterial pressures, and below you can see the baroreceptors output, the action potentials recorded from the nerves of the baroreceptors. What can you appreciate from these pictures? Under normal circumstances, you can see that the frequency of action potential is going. Now what happens to this frequency of action potential when the pressure is increased? When the blood pressure is increased, you can see the frequency of action potential through the baroreceptors increases. Why it increases? Because here, as I mentioned before, baroreceptors are stretch receptors. More stretching of the baroreceptors will take place. You can expect more amount of action potential or more frequency of action potential going through these nerves. Whenever the pressure is low or decreased, there is a less amount of stretching of the baroreceptors. That time you can see the frequency of action potential through these nerves is reduced. Remember, action potential, even if the pressure is low, you will be getting some amount of action potential. It can never become zero. So here the nervous system will be able to know whether the pressure is higher or lower based on the frequency of action potential. Here this is the normal condition, under normal resting condition or normal resting pressure, normal pressure. In this case you can see that the pressure is increased. As a result, the baroreceptors stretch more baroreceptor action potentials are produced. In here you can see that the action potentials from the baroreceptors is less, the frequency is less because the pressure is less and less stretching is taking place. So here you can see the location of the baroreceptors. These are the locations of the aortic baroreceptors. You can see it is on the arch of aorta, and here you can see the location of the carotid baroreceptors, where it bifurcates into internal and external carotid arteries. So that's the location, and that will be having neural connection with the cardioinhibitory center and vasomotor center in the medulla. Now let us see how the regulation of blood pressure is taking place and how homeostasis is achieved. In this case, we are looking at a case of hypovolemic shock. hypovolemic shock. What is a hypovolemic shock? Whenever the blood volume reduces. One of the examples for a hypovolemic shock can be a hemorrhage. When the person meets with an accident, he lost the blood. That's an example for a hypovolemic shock. A blood volume is lost from the body. In this case, the blood volume is reduced. As a result, the blood pressure is also low. Then you can see kidneys. The blood flowing through the kidney is also having low pressure, and also you can see the baroreceptors of the arch of aorta and the aortic sinus. It will be less stretched. All these will be acting as stimulus for the release of further substances, like when the kidney receptors, baroreceptors, there are actually stretch receptors in the kidney as well, and that is going through a particular structure called juxtaglomerular apparatus. You will be learning it later. Juxtaglomerular apparatus is acting as a sensor for the amount of pressure which is exerted in the kidney by the blood. Here it will be giving inputs to the control centers, and finally angiotensinogen will be released into the blood. Angiotensinogen is released from the liver, it is released into the blood, and then a series of reactions will happen where the angiotensinogen will be converted into angiotensin II. There is a series of reactions here which I am not explaining it here. You will be learning it in renal physiology more detail, but let me tell you that angiotensinogen through different steps will be converted into angiotensin II. And angiotensin II is a powerful vasoconstrictor. It has got multiple functions in the body. Now, what are the different functions it is doing? Angiotensinogen is stimulating the adrenal cortex. You can see it is stimulating the adrenal cortex to release the hormone aldosterone. What is the function of aldosterone? Aldosterone we have already learned in endocrinology. It causes more sodium to be reabsorbed the kidney. The kidney will be reabsorbing more sodium, in this case whenever there is more aldosterone which is present. Aldosterone, I mentioned that it is a powerful vasoconstrictor, so it will be causing blood vessels to constrict. Then what will happen to the blood pressure? More constriction of the blood vessel, the peripheral resistance increases, the blood pressure increases. It is also causing the release of ADH from the pituitary. ADH is a posterior pituitary hormone which is actually synthesized in the hypothalamus and stored in the posterior pituitary, but this particular stimulus, the angiotensinogen, it is having a stimulus, or it will be causing a stimulus to release the ADH, and when ADH is released, more amount of water is being reabsorbed from the kidney. ADH will be acting on the kidney and will be bringing about more amount of reabsorption of water. So the blood volume will increase, the blood pressure will go back to the normal. At the same time, here you can see when the baroreceptor is less stretched in the aortic arch and carotid sinus, you can see that the cardiovascular center in the medulla also will be responding by increasing the sympathetic stimulation, and the hormone from the adrenal medulla will be released, right? So these adrenal medullary hormones like epinephrine and norepinephrine will be released. So ultimately it will be affecting on the heart rate and contractility of the heart. The contraction of the force of contraction of the heart is also increased. So finally, what is the results? Look at here. It will be increasing the blood volume, increasing the systemic vascular resistance, and thereby it is increasing the pressure. So here when we are starting, it started with a hypovolemic shock and low blood volume and low blood pressure, but finally it has brought about an increase in the pressure. So it is a kind of a feedback mechanism that will be helping us to cope up with the low blood volume and low blood pressure, and this will be returning this particular response to a homeostatic control. That's all about this particular picture. Now we will look at the hormonal control of the blood pressure. epinephrine or adrenaline. You may have already seen about this hormone, which is one of the important hormone released from the adrenal medulla, the inner part of the adrenal gland. Renin-angiotensin system activated by low blood volume or low blood pressure. So here in the previous slide also we have seen when the blood volume is low or when the blood pressure is low, that much amount of blood which is reaching the kidney with low blood volume and low blood pressure is capable of activating the renin-angiotensin system. And finally, angiotensin 2 will be formed in the kidney, and angiotensin 2 is a powerful vasoconstrictor which will be stimulating the vasopressin secretion. Vasopressin is another name for the ADH. Vasopressin is another name for ADH. It's the same hormone as vasopressin, and ADH is same. So that will be, what kind of hormone is that? ADH will be the hormone which is released from the posterior pituitary. Remember, it is released from the posterior pituitary and it is acting on the kidney to bring about the water reabsorption. So here in this picture you can see vasopressin in bracket ADH or antidiuretic hormone. This will be causing vasoconstriction. Vasopressin, that means it is also capable of causing a vasoconstrictor effect. Other than reabsorbing of water, it is also having an action to bring about increase in the vasoconstrictor effect. There is another hormone which is called as ANP or atrial natriuretic peptide, which is released by the muscles of the heart. It is produced by the atrial muscles of the heart whenever the blood volume is very high. Look at this, the blood volume is high. Remember, this is released only when the blood volume is high, not during the low blood volume. Whenever the blood volume is high, it causes more stretching of the cardiac muscles, which is responsible for the release of ANP or atrial natriuretic peptide from the heart. Its action is on the kidney. It will be stimulating the kidney to secrete sodium, and when the sodium goes out in the urine, more water is also lost through the urine, and thereby it will be causing a reduction in the blood volume. Hence the blood volume is reduced, the blood pressure is also come back to normal, and it has started with an increase in the blood pressure or blood volume. So remember, A and B is secreted only during high blood volume or high blood pressure. So this table is just showing what are the various effects of sympathetic nerves. You can see sympathetic nerve is causing vasoconstriction. It will be on the mean arterial pressure, it is increasing the mean arterial pressure. Epinephrine, it is depending upon the receptor type. If it is alpha receptors, it is causing vasoconstrictor. Beta 2 receptor, it is causing vasodilation. Increase, it is causing increase whenever the dominant effect is alpha receptors. Vasopressin, vasoconstriction will be taking place and it will be causing increase in the mean arterial pressure. Angiotensin 2 is a powerful vasoconstrictor, so it is causing an increase in the mean arterial pressure. In the long-term regulation, as I mentioned, this is again through the kidney. So whenever the blood pressure is low, you can expect the angiotensinogen will be produced. And first thing is that whenever the blood pressure is falling, so you can see when the blood pressure falls, it will be stimulating the kidney to release a hormone called renin, and renin is responsible for the conversion of angiotensinogen to angiotensin 1. Angiotensinogen is released from the liver and it is converted into angiotensin 1 by the presence of renin, which is a hormone from the kidney. After that, what is the next step? The angiotensin 2 has to be converted into angiotensin 1 has to be converted into angiotensin 2, and this is due to another enzyme which is called as angiotensin converting enzyme or ACE, angiotensin converting enzyme. Remember, this enzyme is released from the lungs, Lungs is the source of angiotensin converting enzyme. That means when angiotensin 1, if it has to get converted into angiotensin 2, the enzyme which is acting is angiotensin converting enzyme, which is released from the lung. When the blood flows through the lung, it is the lung which is releasing this hormone. Once the angiotensin 2 is formed, as I mentioned, it is having multiple actions. It is acting on the blood vessels to bring about powerful vasoconstrictor, and then it is acting on the adrenal gland to produce release of aldosterone. Aldosterone will be bringing about more amount of sodium reabsorption, and thereby blood pressure is brought back to normal. So that is there. So here the main important point you need to remember is this one: angiotensin converting enzyme is an enzyme which is released from the lungs, not from the kidney. Angiotensin 2 also causes the release of ADH. ADH is again a posterior pituitary hormone which is stored in the posterior pituitary. So when more ADH is released, more water reabsorption is possible. So long-term mechanisms include all these basic steps. Angiotensin 2 stimulates ADH, and when ADH is there, it will be decreasing the water loss, and also it will be causing a vasoconstrictor effect. What is the another name for ADH? It is also called as vasopressin. Aldosterone, the hormone which is released from the adrenal gland, it is also reabsorbing the sodium ion. When the sodium is reabsorbed, more water is preserved. The thirst center also will be stimulated by the angiotensin 2. There is another action that is of the angiotensin 2, that is stimulation of thirst center. When thirst center is in the hypothalamus, when that is stimulated, the person will feel like drinking more and more water. What will happen when you drink more water? Your blood volume will increase. It will come back to normals. The result will be an increase in the blood volume and increase in the pressure. If the blood volume or the blood pressure increases above the homeostatic levels, more fluid will be excreted by kidney. So that is how the kidney will be regulating the blood pressure. So that is kidney is having a very important role in blood pressure regulation. Remember one important clinical point here. I mentioned that the angiotensin 1 is converted into angiotensin 2 by the angiotensin converting enzyme. From where this enzyme is coming from? It is coming from the lungs. So in patients with hypertension, we can give medications with angiotensin converting enzyme blockers. If you block this enzyme, angiotensin converting enzyme, if you block using a drug, you cannot have angiotensin 2 to be produced in that individual, right? So because angiotensin 1 to angiotensin 2, that conversion is possible only when there is angiotensin converting enzyme which is secreted from the lungs. So here we can use a blocker, and this conversion, if you prevent, you can relieve the patient from hypertension. So in clinical practice, usually you'll be learning more in pharmacology about that. The angiotensin converting enzyme blockers or ACE blockers are used. This is a flow chart which gives the pressure and how it is divided, the mean arterial blood pressure, the cardiac output, which is a product of heart rate and stroke volume. Peripheral resistance is the moving column of blood by the blood vessels itself. Heart rate will be under the influence of hormonal, which is due to epinephrine, norepinephrine, thyroxine, etc., and also the autonomic influence, which is the sympathetic and parasympathetic influence, whereas stroke volume is the one which is determined by the end diastolic volume. So here this part we discussed when we discussed about the end diastolic volume, when we discussed about the venous return. When the venous return increases, the end diastolic volume increases, then the stroke volume will increase, thereby cardiac output is increased. So it is mainly determined by the venous return. So whenever you increase the venous return, according to the Frank-Starling's law, you can increase the stretching of the cardiac muscle, more stretching of the cardiac muscle, and whenever the venous return increases, you can expect the end diastolic volume will increase. So more stretching of the cardiac muscle will take place, the stroke volume will increase, thereby the cardiac output would be increased. And venous return can be increased by different mechanisms, the respiratory mechanisms, which we discussed before also. Whenever the person is breathing, like hyperventilation, like in the case of exercise, the chest cavity will be acting like a vacuum cleaner. It will be sucking the blood like a suction pump, right? So much of blood will be entering into the thoracic cavity because of the negative pressure created as a result of the respiratory pump, and blood will be going inside the thoracic cavity, and the venous return increases. Muscle pump, when the person is doing muscular exercise, the muscle squeezes the blood from the veins, and as you know, the veins have the one-way valve, so it will be sending the blood towards the heart, and venous return increases. And also blood volume is also one of the important factor that is determining the venous return. Sodium and water balance is important, and it is mediated through the ADH. So whenever ADH is more water retention is taking place. Peripheral resistance is the one which is determining the arteriolar diameter and also the blood viscosity. The blood viscosity is mainly dependent upon, in the case of humans, it is the number of RBCs, of the red blood cells. So you can expect in anemic patient, the blood viscosity is reduced. In polycythemia, where the RBC count is more than the normal number, the blood viscosity increases, and thereby peripheral resistance increases. So there are more chances for those patients with polycythemia to have hypertension. Arteriolar diameter is again controlled by the sympathetic activity and also the epinephrine, the hormone, and it is also under the control of vasopressin. Vasopressin or ADH can bring about constriction, and also angiotensin 2. This is not angiotensinogen, it's angiotensin 2. This is angiotensin 2. Now we will see some of the disorders associated with blood pressure. Hypotension, it's a reduction of blood pressure below the normal range. When the systolic blood pressure is less than 90 millimeters of mercury, diastolic blood pressure is less than 60 millimeters of mercury. These categories are classified under hypotension or a low blood pressure. Orthostatic hypotension. This is a kind of situation where the blood pressure falls as a result of postural changes. When from a supine posture or a lying down posture, when the person stands up, there is a sudden fall in the pressure. Usually it is calculated that when there is a definite fall of about 20 millimeters of systolic blood pressure and about 10 millimeters of diastolic blood pressure fall, when the person stands for a duration of 3 minutes. After 3 minutes of standing, if you see a definite fall, a 20 millimeters fall in the systolic blood pressure and 10 millimeters fall in the diastolic blood pressure, they are considered to be having this kind of orthostatic hypotension. Here they will be having some issues with the baroreceptor mechanism. Usually when a normal individual stands up from a supine posture or a lying down posture, if he stands up, immediately there is a fall in the blood pressure. But within fraction of second, our baroreceptors will correct or rectify and make it to normal. But these adapting mechanisms might be abnormal or disrupted. As a result, the blood pressure might fall, and that condition is called as orthostatic hypotension. Usually, it is seen in many of the adult individual, it is elderly individual. Very rare cases there. Chronic hypotension. They are long-term drop of blood pressure caused by poor nutrition, or it could be due to hypothyroidism. Acute hypertension, a rapid drop in blood pressure, most often due to hemorrhage, like in the case of a blood loss. So it is a sign of a circulatory shock, acute reduction of blood flow to vital organs. When it is compromised, it is an alarming situation or a life-threatening situation unless the blood volume is supplemented. Now we will talk about hypertension. Hypertension is a situation where the blood pressure is increased more than the normal range. There are two different types of hypertension classification. Primary hypertension, approximately 90% of the cases falls under this category. The secondary hypertension, there are about 10% of the cases comes under this category. The primary or essential hypertension, the exact cause for the underlying cause is not clear, but there are certain predisposing factors like age greater than 40, obesity, stress, smoking or alcohol consumption, lack of exercise, then the diet which is having high sodium and saturated fat, cholesterol, low in potassium, calcium, magnesium, all these might be the predisposing factors that might lead to a primary or essential hypertension. In this particular part, I mentioned you that you need to make a correction here. The long-term elevation of the arterial pressure more than 130 systolic or diastolic 80 millimeters. They are coming under the category of hypertension. Commonly in elderly and obese individual, the chronic hypertension, which is having some issues, damages if it is chronic hypertension, if the hypertension is there for a long duration, it might damage the arteries and it might be having a pressure or a load on the heart. So the heart will be pumping with more force to overcome the resistance. That's a major cause of heart failure, vascular diseases, and also the renal failure. When blood pressure is kept very high, what will happen is this blood with high pressure flows through the kidney, and there inside the kidney it might cause a rupture of small capillaries, capillary blood. Sometimes you will also see the patient will be having issues with the eye, because here the eye capillaries also might rupture. This is the blood pressure categories or the range according to the American Heart Association in 2017. So this will be again displayed to you when we discuss about the blood pressure in the laboratory session. So here you can appreciate that the elevated blood pressure, the 120 to 129 is considered to be the elevated blood pressure. Less than 80, a diastolic value of less than 80 or a value, systolic value of 120 to 129. These are coming under elevated category. Hypertension stage 1, a patient with a systolic blood pressure between 130 and 139 millimeters of mercury and a diastolic blood pressure between 80 to 89, they come under the hypertension stage 1 category. Hypertension stage 2, 140 or higher, and a blood pressure, diastolic blood pressure of 90 millimeters or higher, they can come under the stage 2, and hypertensive crisis, which requires immediate attention, higher than 180, the systolic blood values, and a diastolic value of higher than 120 millimeters, which is very high blood pressure. Anything can happen. So it's an emergency situation where the patient has to be admitted into the hospital and appropriate treatment has to be done. But remember, when you are recording the blood pressure, if it is within the elevated range, you need to always be careful. You need to do the lifestyle modification, or some people might have to find out the cause for why their blood pressure is elevated. So these things, more details, we will be discussing again during our practical sessions in the upcoming sessions. That's all, and these are the references. Once again, thank you for listening.